I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. Wow, September, we're halfway through September. I can't believe we're already this far in the year. Thank you all for joining us tonight from wherever you may be joining us from. We are thrilled to have you. As many of you know, tonight's living room is going to be about small cell lung cancer. We talk a lot about non-small cell lung cancer in this meeting, but we decided it was time to dedicate an entire living room to small cell. As the title indicates, it's not so small anymore, and we're going to be discussing the expanding portfolio of biomarkers in small cell lung cancer with Dr. Christine Lovely. Dr. Lovely is the Associate Professor of Medicine in the Division of Hematology and Oncology, Ingram Associate Professor of Cancer Research, co-leader of Translational Research and Interventional Oncology Program, the Section Chief in Basic and Translational Research. Ooh, that was a tongue twister. Vanderbilt University Medical Center and Vanderbilt Ingram Cancer Center. And she is also the chair of the GO2 Foundation Scientific Leadership Board. So welcome, Dr. Lovely. So with that, I would like to jump into what is small cell lung cancer, Dr. Lovely. Tell us a little bit about what it is and how it's different than non-small cell.
Okay, so I want to again thank everyone for being here tonight because you are choosing to spend your night with us, and we're really happy that you are here. So small cell lung cancer, we definitely don't talk about it as much, and a lot of reasons, and we could fill several living rooms with the discussion of small cell. Small cell lung cancer is a different type of lung cancer, so it's from a different origin. About 85% of all lung cancers are non-small cell. That's what we're most used to hearing about. About 15% are small cell. Small cell is what we call a neuroendocrine tumor. And that just has to do with where the tumor started in the body. Small cell is quite a different beast than non-small cell is, as many of you have started to become familiar with. So small cell lung cancer, different origin, looks very different under the microscope. The reason they call it small cell is because the tumor cells look like small round blue cells. And it's one of many small round blue cell tumors. It is a diagnosis that's made right now based on histology, so what a biopsy looks like under the microscope. And I'll stop there as we can kind of carve the layers of talking about small cell lung cancer, because there is really a lot to say in this area.
Can you talk a little bit about how small cell lung cancer is staged? I know we talk a lot in the living room and in a lot of our education materials around stage 1, 2, 3, and 4, but small cells staged a little bit differently. Can you explain how it's staged and what the differences are?
Yes, and it's confusing. And so we usually think about any cancers as being stage 1, 2, 3, 4. And certainly we have those stages for small cell lung cancer, but on a practical level, how we stage it in clinic is limited stage or extensive stage. And so you'll see LS-SCLC or ES-SCLC. So extensive stage is kind of analogous to metastatic disease or stage 4. Limited stage usually means that a medical oncologist in conjunction with a radiation oncologist has said, okay, this tumor is confined to one part of the lung, one portion of the thorax, the chest area, and I can radiate it. And so this is really a diagnosis and a treatment plan that has to be made as a multidisciplinary team with a medical oncologist and a radiation oncologist. And it really depends on just where the tumor is located.
What are some of the symptoms of small cell lung cancer? I know we talk again a lot about people being asymptomatic until the disease is more extensive, but what do they look like in small cell?
Yeah, and small cell can actually look quite different too. And in my experience, patients with small cell tend to be a lot more symptomatic than patients with non-small cell. Not always, and there's no hard and fast rules, and can look a lot of different ways. But patients with small cell tend to be, a lot of weakness and fatigue, often coughing, similar non-specific symptoms to lung cancer. But what's unique about small cell lung cancer is it can present with these phenomena that we call paraneoplastic syndromes, and that's a big fancy word for something that means in addition to the tumor, your body is either secreting hormones from the tumor or trying to mount an immune response to the tumor. The problem is that can result in side effects or symptoms from small cell, like profound weakness and trouble with muscle strength, trouble with walking even. We've seen patients present with seizures. It can look a lot of different ways. And I think for lung cancer in general, that's one of the biggest challenges is the symptoms overlap a lot of other possible disease states.
So is that, just so I understand, because this is new to me too.
Yeah.
That paraneoplastic syndrome is specific to small cell. We don't see that in other types of lung cancer.
Very, very, very rarely. It's more common in small cell than it is in non-small cell. And not every patient with small cell will have a paraneoplastic syndrome, but those who do tend to be a lot more symptomatic.
Are there studies being done on this? I mean, how did we find this to be a symptom of small cell?
Yeah, so let's actually take a step back and start from the origin of how do we even find small cell? Are there screening studies? How do patients get diagnosed? And kind of compare and contrast with non-small cell. So the first thing is everybody out there probably has heard about lung cancer screening and low-dose CT scans to try to find lung cancer in what's considered to be high-risk patient groups. It is more difficult to detect small cell lung cancer with screening because it tends to be a tumor that grows very quickly. And so in between 2 years of screening, 1 year of screening, it may be that the tumor appears in between the screening tests. And so take-home message is, it's been challenging for us to do screening for all lung cancers, but especially screening and early detection for small cell. Once it is diagnosed, it's typically with a biopsy, the same way that we would diagnose non-small cell lung cancer. But again, small cell looks different under the microscope than non-small cell does.
Are there challenges related to biopsying small cell lung cancers?
Yeah, so actually, I'm not a pathologist, but what I understand from my pathology colleagues is it's actually quite straightforward to make a diagnosis of small cell lung cancer under the microscope. It has a very, very characteristic appearance. And so what that translates to sometimes is that instead of getting these core biopsies like we're used to getting for non-small cell lung cancer, we get smaller biopsies or something called an FNA or fine needle aspirate. And that's helpful because it helps us to make the diagnosis of small cell, but it doesn't give us a lot of tissue to work with for downstream studies in a research laboratory, which in my opinion has been problematic over the years because we just don't have tissue to study this disease as much as we do for other types of cancer.
So I want to talk about how small cell lung cancer is treated. Mm-hmm. And I'm not sure if we want to talk about biomarkers and whether or not they're used in treatment of small cell lung cancer before or after. I know we have kind of gone back and forth with this.
So let's compare and contrast to non-small cell because I think that's an easier framework. Just like non-small cell lung cancer, small cell lung cancer is diagnosed with a biopsy. You require scans, CT scans, PET scans, sometimes MRI of the brain. When the diagnosis of small cell lung cancer is made, in stark contrast to non-small cell lung cancer, we typically don't do tumor genetic testing of the tumor because there's not like EGFR mutations in de novo small cell, and I know a lot out there are like, well, what about transformation? And that's a whole nother topic that we can get into. But if standard of care right now is if you're a patient who's diagnosed with small cell, we don't get the same tumor genetic testing that we do for patients with non-small cell lung cancer, because there's not been found to have the same therapeutically actionable mutations. So for example, we don't test routinely for EGFR or ALK or ROS1 in all small cell lung cancers. And there's not drug targets that we are looking for, at least in 2020, in patient tumors.
Question on that. You know, we have a lot more markers today than we had 5 years ago or 10 years ago.
Yep.
Do you think if we started testing small cell cancer patients now, we might have a bigger opportunity to find some targets that could be helpful?
Yeah. For those of you out there, there's many things that we can test in a tumor. We can test DNA, RNA, we can test something called the epigenome, just lots of ways to understand what's making the tumor tick, what's making it do all the bad things that tumors do. And right now, we can do all sorts of those kind of tests in the laboratory, but there hasn't been a smoking gun, so to speak, in the clinic. There's not been, any one DNA marker or RNA marker or protein marker that has said, oh, aha, this is what we're going to test for, and it's going to help us direct our therapy for our patients.
So based on that, historically speaking, we know chemotherapy was pretty much the option for lung cancer patients. What's happened since then? And let's start kind of with, the earlier stage patients, and then we can move into the next category.
Yeah, so let me say, this is an area that is so high priority for research for the NCI, the National Cancer Institute, that in 2014, they actually put out basically a call for, hey, help us, we need to figure out small cells. So the National Cancer Institute, which is a subdivision of the National Institute of Health, actually called small cell lung cancer what they deem a recalcitrant tumor. What that means is that, at a very high level in our government, they said, we have not had as much advances in this disease as we want, and we need to put some effort towards really studying it. And so there are a lot of very active groups studying small cell lung cancer right now, but still not that smoking gun biomarker. I believe that we'll get there. Your question about, where do we start in terms of treatment is tied to this whole concept of it being, a recalcitrant malignancy and a recalcitrant tumor type. And why is that? Because the treatment that we use right now, the cornerstone of the treatment that we use right now, which is platinum-based chemotherapy, either cisplatin or carboplatin, with a chemotherapy drug called etoposide, those two medicines have been what we've used for this disease since the early 80s. So decades of time where despite trials, despite development of new therapies, there has not been a change in that foundation of that chemotherapy regimen that we use for small cell until this year. And this year is when we started to bring in immunotherapy into the treatment of patients with small cell lung cancer. And so let's kind of maybe break it down by how do we treat limited stage versus how we treat extensive stage before we get into the new development, so that we can all have a foundation for how's this tumor type treated and what's different from the non-small cell paradigms. So let's go back to limited stage small cell lung cancer for a minute. So limited stage small cell lung cancer, it is usually in like one portion of your chest. And a radiation oncologist and a medical oncologist will get together and say, okay, we're going to diagnose this patient with limited stage small cell lung cancer. And we're going to treat the patient with concurrent chemotherapy and radiation. What that involves is giving weekly chemotherapy and daily radiation, although weekends are usually off, to the patient for several weeks. So it is aggressive therapy, chemotherapy and radiation together. And after a patient gets through those two treatments, and their chemotherapy is platinum etoposide, and platinum can be either carboplatin or cisplatin, and the radiation is prescribed by a radiation oncologist. After that is done, what will typically happen, and this is very unique to small cell lung cancer, is if the patient hasn't had a nice response to chemotherapy and radiation together based on CT scans, your medical oncologist will talk to you about something called prophylactic cranial irradiation, or PCI. What that is the chance of small cell lung cancer going to the brain is so high that in previous studies, they've asked, even if a patient does not have brain metastases, there's actually some benefit to prophylactically or preventatively giving radiation to the brain to try to prevent the cancer from spreading there. And so for a patient with limited stage, usually confined to one part of the chest, chemotherapy and radiation, need a multidisciplinary team. Surgery is not impossible, but it's not used very much, and I hope that changes. After chemotherapy and radiation, it would be PCI, or prophylactic cranial irradiation, to try to decrease the risk that the small cell lung cancer will come back in the brain. Let's pause there for a second about limited stage, and then we can go into extensive stage and kind of describe how we treat extensive stage and what the new advancements over the past couple of years have been.
We get questions all the time. This is a big fear
Yeah.
for patients when they're told that they need this radiation. How do you get them to understand that this is a benefit?
Yeah. Yes, so it is a difficult conversation. And I would say usually it's a conversation that you're having with the patient, with yourself as the medical oncologist, and then also with the radiation oncologist involved too. And we say, or try to articulate, to try to be as aggressive as we can be in treating your cancer. We actually have data or information from clinical trials showing us that if we do the prophylactic cranial radiation, or PCI as we call it for short, that can really help you do better from your cancer. And it is not without side effects, but the doses that are of radiation that are used for PCI, or prophylactic cranial radiation, are not the same as the dose of radiation that we use to actually treat brain metastasis. So there is a difference there, but it is a challenging conversation, really, that is aimed at saying, we want to give you every fighting chance you possibly can have to knock this cancer in the bud. And part of that is offering PCI.
Thank you for that. Is it true, whether with limited or extensive or both, that patients will typically respond really well up front to this type of first-line treatment?
Yes, that is absolutely true. So one of the many very challenging things about small cell is, if a patient is treated with chemotherapy, we fully expect to see the majority of the tumor shrink. The problem is that when it comes back with a vengeance, and it becomes more difficult to treat. And the way we treat it depends on how soon it comes back after chemotherapy. If it comes back 3 months, 6 months, 9 months, a year, 2 years, that changes our treatment planning process as we think about, patients very often have very dramatic responses to chemotherapy or chemotherapy radiation. The problem is it comes back and it becomes even more difficult for us to manage. And so everything and anything we can do to optimize that first treatment that the patient has to try to prevent it from coming back is what we need to do.
One of the biggest challenges, and one of really the saddest things for me in talking with patients that are diagnosed with small cell, is quite often they will deny treatment altogether because there's so much misunderstanding, I think, about this disease. So I think it's so important to let patients know that these things, they do work, right?
And
the coming back with a vengeance, I think, is something we can talk about, but to kind of quell those fears. Can you talk a little bit about the quality of life with this type of treatment?
Yeah, you read my mind. So I was going to say, and this is an important message, is that sometimes chemotherapy can make people feel better. So there are plenty of instances, especially with small cell, when a patient is very symptomatic from the tumor, when we treat the tumor, they tend to feel better. And so it's not uncommon to actually have people go through chemo and start to increase their activity and not decrease their activity. Treat the tumor, which reduces the symptoms from the tumor, and the patient starts to feel better. And so it saddens me to even think about a patient with a new diagnosis of small cell not considering treatment, because I do think there is a tremendous benefit in terms of palliation, or just treating the symptoms from the cancer itself, that cannot be minimized.
Christine, we see patients all the time that are terribly fearful of chemotherapy.
Yeah.
Can you talk a little bit about chemotherapy today versus chemotherapy 10 years ago? Because
Absolutely.
we're using it as a booster for immunotherapy, and
Mhm.
it's really become a new therapy for patients.
Yeah, so I will say when I was growing up, I remember watching TV and movies in the 80s, and all you saw was patients with cancer in the bathroom, vomiting and just feeling miserable. That is not the case. And it's not necessarily because our chemotherapies has changed. It's because when we give chemotherapy as medical oncologists, it comes along with a host of drugs that help to minimize the nausea, to minimize the vomiting, to help with any symptoms related to chemotherapy itself. And so the supportive care medicines that we give with chemotherapy, and that's the chemotherapy for small cell, it's the chemotherapy for non-small cell, it's the chemotherapy for tumors outside the lungs. They are better tolerable because the advances in the supportive medicines, like the anti-nausea medicines, have been really profound in the past few decades.
I think that's also a really good point, especially when we talk about the supportive care or the palliative care that kind of comes along with it. Quite often patients will hear the word palliative and they want to run and put their heads under the covers because there's another big misunderstanding about what that means. That's not necessarily specific to small cell, but just in general. So I think it's super important for patients to have those conversations about that supportive type care with their physicians.
Absolutely. I 100% agree. And how I like to phrase it and talk to my patients about it is, you need a team. And that team is going to include multiple doctors. And one of those doctors should be, if you have accessibility to it, a doctor who is an expert in pain and symptom management or palliative care. And that name has a lot of stigma around it right now. It's almost like we need to come up with a new name for it. But I would say that having a pain and symptom management or somebody who is an expert in symptom control or palliative care does not mean you're going right to hospice. It means that we want to be as thoughtful as possible as physicians to say, what is everything we can do to make you feel better? It's not just about giving chemotherapy and doing CT scans. It's about making sure that quality of life remains as high as possible, that we are thinking outside the box in terms of how we address symptoms when they come up. And honestly, probably everybody who's listening knows this. It really, in 2020, medicine takes a village. And you want that because everybody has their own area of expertise. And we are very used to working together. This is not a one man or woman show. This is all hands on deck to help our patients.
So while we're sort of on this topic, and I don't want to derail us from moving along in tonight's discussion, but how important is it for patients to call their physicians when side effects maybe are becoming too much? And let me kind of step back and tell you that I'm asking that because I've heard, patients, they're afraid to call their doctors and tell them, oh, I'm suffering from X, Y, or Z, because they're fearful their doctor's going to take them off of a certain medication.
Yeah.
How important is it that and when should patients call to let you know that something's changed?
Yeah, I think that's a really great, important and sometimes difficult question because how do you know? You're going through this for the first time. It's sometimes hard to know what's from a drug, what's not, and honestly, all the normal things as part of life happen while you're going through cancer treatment too. You might get the flu, you might get an upper respiratory tract infection, and so I would say when in doubt, talk to your team, and your team is your doctor or your multiple doctors, all of their support staff, nurse practitioners, advanced care providers. It is, if you're thinking in your mind, I'm not sure what's going on, it's worth asking because for any symptom, it is easier for us to treat it when it gets started rather than when it gets worse. So pain, for example, we have this concept called pain crisis, that it gets increasingly difficult to get the pain under control if it's not managed early. And so I would say for anyone out there listening, if you're questioning and you're thinking, should I talk to my doctor? Better to err on the side of caution and talk to your doctor and your team of doctors and all of their support staff, nurses. I mean, there are a lot of people out there to help you.
Yeah.
Dave Johnson, who was my clinical mentor when I was in training, one of the grandfathers of excellence in the lung cancer world, he had himself, and I'm not sharing anything private because he talks about it publicly, he had lymphoma. And he told me, and this stuck with me so much, he said, Christine, once you have cancer, you never have a headache again. And what he meant was, once you have a diagnosis of cancer, everything that happens, the first thing you think is, this is my cancer. And that is a lot of anxiety and a lot of stress to deal with. And I think everything we can do, and it's not even just about symptoms, it's about supporting patients' emotional well-being, trying to have support networks and patient groups, and that's really the power of these type of forums. It's, we treat the whole person. We don't just write a prescription for chemotherapy and say, I hope this works. We want to make sure that everybody is getting the best care that they can in terms of available data on a scientific level, and couple that with caring for the whole person. We're not caring for a tumor. We're not caring for small cell. We're caring for the person who happens to have small cell or non-small cell lung cancer.
Move on into extensive stage and talk a little bit about the roles each treatment sort of bucket, if you will, has in that small cell lung cancer patient.
Yes. So for extensive stage, this is where we've seen the most advances over the past about year and a half. And so it used to just be that patients with extensive stage received chemotherapy, platinum etoposide. Now, several trials have shown us that if we add immunotherapy to platinum etoposide chemotherapy, that there is a survival benefit, meaning patients live longer when immunotherapy is added to chemotherapy. Two big studies that have come out in about the past year and a half with two different immunotherapy drugs, and they were actually remarkably similar in terms of the outcome. So in one trial, they combined platinum etoposide chemotherapy with a drug called atezolizumab. In the other trial, they combined platinum etoposide chemotherapy with a drug called durvalumab. Both of those are what we call PD-L1 inhibitors, and we can get into that. But what this trial showed us is that if you add immunotherapy to chemotherapy, there's about a 2-month survival benefit. Now, and hearing myself say this, it sounds like I'm like, well, this is great. We have a home run. We don't. We're excited about it because it's been the first new treatment paradigm in small cell lung cancer in about 3 decades. But survival for extensive stage treated with chemotherapy and immunotherapy is 12 months, 1 year, compared to 10 months with just chemotherapy alone. And I think everyone out there agrees that is not good enough. In 2020, telling a patient, and never at any time is it good to tell a patient those kind of statistics. And certainly we need to push the bounds a lot more to really try to get patients to live longer with small cell. And so immunotherapy with chemotherapy and advancement in extensive stage small cell, we still have a long way to go. And I remain very hopeful that coupling science with clinical trials and really creating a voice for this type of tumor and a space to discuss it will help make those advancements possible.
And I think it's important to note at this stage too, because you're right, hearing a 2-month survival benefit doesn't sound like a home run. And to your point, again, it's not. I think it's important to point out that this is the median, right? So people fall on either side of that as well.
Exactly.
And nobody gets to decide where you're going to fall on that curve. And I also think it's important for patients to have sort of these goals of care conversations with their physicians, because 2 months might mean a grandchild's first birthday or somebody getting married and it's a wedding you want to attend.
So important. I like to say, you're the quarterback to my patients. You're the quarterback of this team, and I'm going to be right there with you. But we are here to make recommendations and help you make the decisions that make the most sense to you based on what your goals are and what your family life is like and what you want to do. And that cannot be underemphasized. I think that is something we need to talk about a lot more. We tend to get into data, and that's important. And don't get me wrong, I'm a huge advocate for science. That's what I do for a living. But I think we need to couple that with respect for individuals. And personalizing care, to Bonnie's point, means not just writing a prescription for a drug based on some kind of tumor characteristic, but helping to tailor care that makes the most sense from every individual patient on a personal level as well.
Yeah, I love that. And I think those sometimes are the harder conversations to have, right? Science is science, and you can point to look, right? But having those hard conversations are equally as important. I think both for the physician and the patient and their family members. So you talked about PD-L1. Do patients with small cell lung cancer need to be tested for PD-L1, or are they just given the immunotherapy?
Oh, so the trials that brought immunotherapy into small cell lung cancer were not stratified by PD-L1. So unlike non-small cell, where we use actually PD-L1 to decide if a patient can get single agent or single drug immunotherapy versus chemotherapy plus immunotherapy, we do not in 2020 use PD-L1 as a diagnostic marker in small cell. In fact, the minority of small cell lung cancers even express PD-L1. And so I think this is an area of big research in my lab and many other people's labs as well, is trying to understand what is the immune system doing in small cell? If PD-L1 is not an important marker, what are the important markers? And how do we really use that information to make better trials for patients with small cell lung cancer?
That's great. I know that myself and others, and obviously you and all the wonderful docs and healthcare professionals out there taking care of these patients have seen non-small cell lung cancer transform to small cell. Can you talk a little bit about what we know about how often that happens, or maybe even why?
Yeah, so that's a great question, and I think this topic will resonate with a lot of people who are listening. So we know the most for patients with EGFR mutant lung cancer, where when treated with an EGFR inhibitor like osimertinib, about 10 to 15% of those patients, when they become resistant to osimertinib or when their tumor stops responding to osimertinib, that the initial type of cancer, the adenocarcinoma, which is a non-small cell lung cancer, actually changes to a small cell lung cancer. Why that happens, we're not sure, but it has major implications for patients because we treat small cell very differently than we treat non-small cell. And so the mechanism or the scientific basis for how a tumor goes from being non-small cell lung cancer with adenocarcinoma pattern to small cell lung cancer is not understood. There are a lot of people, a lot of very smart people studying this. The National Cancer Institute has actually, put out special grant mechanisms to say we need to understand this because it's not even just in lung cancer that patients with prostate cancer can also have this transformation to like a small cell type histology or more broadly speaking, neuroendocrine. And so I think there's a lot of impetus in the scientific field to understand this, but right now, if a patient has a transformation, we call it histological transformation, and what that means is just the pattern of the tumor changes under the microscope after a therapy. When that happens, the paradigm is we treat the patient as if they no longer have non-small cell lung cancer, now they have small cell lung cancer.
So this might be a silly question, but it just kind of struck me. Is it possible that the small cell was there all along? And just not identified? Okay.
Yes, absolutely. And so there's two ways that this could happen. Either the small cell was there all along, but it was a very, very minor fraction of the tumor, or there was actually a non-small cell tumor cell that changed into a small cell tumor cell, or both. We don't know. If I had to guess, which one do you think is going on? I suspect there's probably a component of small cell in a lot of these tumors to begin with that we just can't detect. Because you're basically looking then for a needle in a haystack. I think as different diagnostic studies get better and better, not just DNA, RNA, methylation status, protein markers that will be able to detect different tumor cells and what we call single cell technologies. Because right now, we don't look on a cell-by-cell basis at the tumors. We look at the bulk tumor. But what's really evolving in the scientific space is these single-cell technologies where you look on a cell-by-cell basis to try to figure out what's going on. And I think that will really make huge strides in understanding non-small cell lung cancer going to small cell lung cancer. And I will say there's also been case reports of patients who have non-small cell lung cancer treated with immunotherapy, and when the tumor becomes resistant, it looks like small cell. So this is a paradigm that we're really trying to wrap our heads around in the lung cancer space, but don't have a fantastic explanation for why it happens right now.
Somebody online is asking about sort of life expectancy. As you said, a lot of patients do want to know, and this question isn't specific to them, but on record, as far as you know, what is the longest amount of time someone has lived with small cell? This patient was diagnosed in 2014, so 6 years is a long time.
Yeah, so I mean, it's rare, but there are some patients with limited stage small cell who are cured with chemotherapy and radiation, meaning they have long-term benefit. I would wish it was more. It's still pretty uncommon for patients to have years and years of benefit with limited stage, but that's why we really try to push to be as aggressive as possible initially, so we offer everything we can to try to get to that point of cure. We know that for any cancer, once it's spread outside of its original site of origin, it becomes more difficult to treat. So metastatic cancer across the board is very challenging to treat, and we rarely talk about cures. And the same is true for small cell. For limited stage small cell, the minority of patients, but not zero, can actually be cured from chemotherapy and radiation alone.
And I'm curious, going back, since we're talking about limited stage, is that why you had made mention that there's hope in the future that they will kind of bring surgery back into this limited stage space, because it's very rarely done now? Do we think that might have some impact on what you're saying?
Absolutely. I think part of the team for lung cancer specialists is medical oncologists like myself, a radiation oncologist, which you talked about, and surgeons. And if there's any possibility of taking out a cancer, we want to be able to offer that opportunity. I think some of the studies looking at surgery in small cell are quite old right now and need to be reevaluated. And I'm not a surgeon, but I think surgical techniques advance just as chemotherapy and radiation advances. I think having the ability to take out a tumor and then actually get a big chunk of tumor to study is also incredibly important to move the field forward. You think about tumor types where there are a lot of treatments, other common tumor types, it's often for the very practical reason that they have more tumor to study. And that helps to really understand the biology of the tumor, which then helps to make better trials, which then helps to make better treatments. And in the absence of surgery, we just don't have a ton of small cell the tumor tissue to actually work with and study. And so I'm very hopeful that surgery will come more and more into the treatment of patients with small cell. At one more point, I think this is why it's so important to have a multidisciplinary lung cancer tumor board, where you have different experts across different specialties in medicine sitting together and saying, what are we going to do with this patient? What's the best, and how do we personalize the treatment? And there's lots of guidelines and algorithms, but every patient is unique, and we need to consider each context individually.
So moving along a little bit, what clinical trials are currently available for patients with small cell lung cancer? Yes. And I guess I would like to ask, how and when do you have those conversations with them?
Yeah, so let's start with limited stage. I think one of the biggest trials out there right now with limited stage is trying to incorporate immunotherapy into the treatment algorithm for patients with limited stage disease. And so look for those coming with the same agents that we just talked about. Durvalumab is one of them. Can we move immunotherapy into earlier stages of the treatment of small cell lung cancer? For extensive stage or the more advanced metastatic small cell lung cancer, we just had a new drug approved, actually, a drug that's very different from other drugs we've used in small cell, a drug called lurbinectedin. It's actually a natural product, so it came from a sea anemone deep in the ocean and became a drug after years and years of study. And that is a new second-line treatment for patients with small cell lung cancer, which is moving now into the first line. So there's trials using this new drug, lurbinectedin, in the first line. There's also thoughts about other agents, in the first line treatment, which means the first treatment the patient ever saw, and after. So PARP inhibitors, which are drugs that can interfere with your tumor's ability to fix its DNA when the DNA is broken. That's a big area of research. Drugs that inhibit or block a pathway in the small cell called Notch inhibitors have come more and more into clinical trials. I think, especially for any lung cancer and small cell, in particular, perhaps, is patients are often so symptomatic that it can be challenging to get them on trial, and making sure that we're talking early and often about availability of trials, about the importance of trials, and really pushing the platform that way is incredibly important. There's not multiple lines of therapy or multiple options for small cell, and we need to really work as a team across our entire country and our entire world to get patients on the trials so that we can actually make the advances that we needed. And I'm sure you've talked about it in this context before, but one of the challenges with small cell trials is trials are often limited to certain patients of a certain performance status, meaning you have to have a certain level of day-to-day functioning. Well, patients with small cell tend to be so symptomatic, tired, fatigued, weak, coughing, just very, very more put down, if you will, in terms of their day-to-day life, that they sometimes don't even qualify for the trial just based on performance status. And like we talked about before, performance status can actually improve with therapy when we treat the tumor. And so I think while we also try to advance the drugs that we give, we also need to really rethink the way we design clinical trials as well. And I know that's something that Bonnie is very passionate about.
She absolutely is. I don't know if you want to say something about that or just thumbs up.
Mm-hmm.
Yeah, no, I couldn't agree more. And I think, one of the challenges that we hear about too, particularly with patients who are seen in more rural communities, the physicians, they're seeing a general oncologist who's treating whatever walks in the door. And I say this all the time, probably almost at every living room. And I think it's an unfair expectation to assume that general oncologist is going to know everything there is to know about every type of cancer that walks through the door, right? So it's important to educate yourself and become your own advocate as much as you can, and B, find there are resources out there that can help you. If a clinical trial is something you think you might be interested in, GoTo has a program that we call Lung Match, and we have some amazing PhDs that work as navigators, part of the time on this Lung Match program, where we will help you try to find a clinical trial in your area. So things like that and others, I think, are an important resource that patients should know about.
One of the exciting things and a silver lining that has come from COVID is actually many physicians doing telehealth. And I think that is going to be a key factor in lung cancer discovery and lung cancer care. And it's going to help those physicians that are in the community hospitals and the networks that aren't experts in lung cancer, that they'll be able to hopefully dial into some of the physicians like you as well and say, hey, I've got a patient here and I'm just really not sure what to do, where we can collaborate and all work together using Lung Match and all of these other opportunities we have for patients to get them to the right drug at the right time.
But there are some minor differences, I think, when it comes to small cell lung cancer patients, particularly when it comes to access, equity of care. I mean, we could run down the list, stigma. One of the big things that I want to point out and talk about once you're done is a sense of community that just really isn't there in the small cell space. So can you talk a little bit about some of those disparities?
Yeah, so I'll start with the sense of community. I think, this is sad to say, but it's true. Patients with small cell haven't lived long enough to make that community, which is horrific, and something we need to change. And so, I think having patient voices in this area is incredibly important, as it is incredibly important to have patient voice in every area. In terms of disparities, this is something that exists for lung cancer in general, and everybody out there who's listening knows this, is what's the first question you get asked? Did you smoke? It doesn't matter. Let's put that aside. In our country right now, and I'm concerned that COVID is actually going to make this more difficult, is we have significant issues with access to care, whether you live in a city or rural, what type of insurance you have, what you look like. It doesn't matter. Cancer is all of our enemies equally, and we all equally experience it at some point in our lives. We may experience it in a different way, but it has to be we're all in this together. And this is a huge and incredibly important topic. But if we're going to deliver on the promise of precision medicine, it means that we have to take everybody into account, make sure that we have enrollment in clinical trials across every color of skin and every different background, and whether you live in the city or the country. We need to make much broader strokes with that. We need to understand how different patients' tumors react differently based on their ethnic background. Not every tumor is created equal, and that's the whole premise of small cell of precision medicine and access to care. That is, to be honest, something that is one of the things that keeps me up at night, because when we see people who can't get the care that they need because of whatever reason, whether it's their insurance or they can't get to the hospital, or it's absolutely horrifying. So this is a huge and important topic. I think it's going to take organizations like GO2 to help us spread the message nationally and internationally. Lung cancer has a voice, and that voice is blinded to what gender you are, what's the color of your skin, what religion you practice. Is that this is an enemy that we share and we fight together.
I could not agree with you more. And I think it's important to point out too that caregivers, family members, friends, loved ones can also advocate for these types of things, right? So the voice doesn't necessarily need to come just from the patient.
While we, on one end of the spectrum, work to make better drugs, make better trials, we can do all that work, but if we can't actually deliver that to people, then so what? And so this is something that absolutely has to access to care, equity in care, addressing disparities. Whether you live in New York City or San Francisco or rural Alaska, you deserve to have the best care for whatever cancer you have. In this case, we're talking about lung cancer. And how do we make that happen? Bonnie looks like she's about to say something too.
Christine, I love your passion. I absolutely love it. And I could stay on this. I could stay on this call all night long about this subject, this absolute subject. 50% of trials, all the trials in the United States happen in 10 states. And we can pick them off with our fingers and know exactly who they are. And not to criticize, because, that's a step in the right direction. But we need to bring research and care to the patient. We have to stop making them find it on their own. That's too much to ask.
One of the things that we didn't touch on, but we could spend an entire living room talking about, is the financial burden for a lot of folks out there in order to receive this great care, because it's not as easy as being down the street from Vanderbilt, right? Sometimes people can't keep their phones on, right? Let alone figure out how to pay for their cancer care or get a ride to their chemotherapy treatment, right? So I think there's a lot of spokes in this wheel. And I know Dr. Lovely is working hard on it on her end. I know we at GO2 Foundation are working hard on it on our end, as well as many, many others around the world. Finally, a huge thank you to Dr. Christine Lovely for coming out and giving us this wonderfully heartfelt conversation around a not so easy topic. I appreciate, as we all do, your taking the time to do that for us. With that, we're going to close out, and it was great to see everybody. Thank you so much. Enjoy the rest of your Tuesday, wherever you may be, and we'll see you next month.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.